All right. So today we're going to talk about chapter 6, which is diagnostic testing, which I don't know why some reason I had it in my mind it was death and dying. And I figured nobody should have to talk about death and dying on a Friday. But it's diagnostic testing. So then I perked up a little bit. So we're going to do that, and then we're going to look at some more instruments. And if we have time, I have a couple review activities for us regarding lab this week. However, if we don't get to that, Monday is completely devoted to like lab stuff. So we'll pick it up there. Okay. So that's pretty much the plan for today. A couple announcements. One, for the project, so listen up, team leaders. Everybody else listen up, but team leaders too. For the part 2 next week, part of it is to do a Flipgrid video. And everybody is going to do one, and you can get the Flipgrid app on your phone, or I think you can do it on the website, but to record, I think you might have to be on your phone. So I would say the app on your phone is probably going to be better. In the information for the part 2, I added the link to get to the Flipgrid. However, there's a little caveat, and this is what I want you to remember, that to create your account for Flipgrid, you have to use your PMI email. Okay, that's the thing. So if you're trying with your personal email, it won't work. It has to have that my.pmi.edu shenanigans. Okay, so my suggestion would be to maybe create that now. Like, you don't have to wait to create your account just so that you can kind of get an idea of it. And I guess you can record your Flipgrid as early if you would like to, but it's about a revised study space. So you don't want to record it until you've revised, spruced up your study space, okay? Because that's what it's going to be about. Questions about that? Does that make sense?
When you sign in, do you go as student?
Yeah, you're going to go as student.
There's one that says enter flip code.
So the code is actually that last part of the link. So did you get the link, or are you just adding an account?
Adding the account. I was just trying to see, just to make sure it was the right one.
Actually, I lied, because you can't access the part 2 until the day of the thing. So
okay.
Just set up your account, and then when it comes time, the link, the back part of the link is the code, or you can just copy and paste that whole thing.
Okay. Thank you.
Yes, ma'am. Thank you. Other than that, on August 15th, which is a Saturday, and 1 week from my birthday, we are going to have a lab organizing party, and I am going to provide the pizza and passes for anybody who would like to come and volunteer at the campus on Saturday. We can't have more than 10 people in a space at a time, so we might have to do time slots. So we can figure that out, but if you are interested, reach out to me and let me know. We were thinking we would probably start about 9 a.m. on Saturday, but if a bunch of you, and we're asking cohort 3 as well, we might have to do, like, one group comes for a couple hours, another group comes for a couple hours, but our goal is to just reorganize the lab. We're going to be going through cabinets, reorganizing supplies, getting rid of any items that we don't need. We also have a new storage space. So we have a bunch of extra stuff that's been gifted to us from different facilities, and we've stashed it in an area that is really belonging to the vet program. And the vet program is going to be hatching little ducklings. And so they need that space to hatch their little ducks. And who would want to stop the hatching of little ducks, little baby ducks? So we need to get our stuff out of there. And so there's another space that we also need to clean and organize that we're going to be moving that stuff to. So that is going to happen. Your birthday's that Sunday, Robbie. Come on, this is a party to celebrate your birthday.
Okay. I rented a cabin on Airbnb in Moods Park, and I never been there, so I wanted to get out the heat.
That sounds fantastic. No, that's totally fine. There might be additional opportunities. This is just going to kind of be our first run. So anyways, it's the 15th. August 15th is going to be the date. Would it be helpful if I posted that as an announcement in your Blackboard? Okay, let me do that for you. Let me make me a little action item note. Post announcement. Okay, so
It would be 9 a.m. to what time?
I don't know, until we finish, or as long as you want to stay. So if you can come for a couple hours, I don't know. I would say we're like myself and Mrs. Brombeck are probably going to put in a full day of work there. But so, you know, maybe 9 to 4 or 9 to 5 or something like that. So if there is a time during those hours that is more conducive for you to come, then we'll probably be there during those hours. Is that helpful?
Yeah, thank you.
Okay, you're welcome. So I'll post that announcement. I think that's all the update stuff that I have. Do you guys have anything for me? Okay. Awesome. Awesome blossoms. Alrighty, so I'm going to share my screen with you so that we can look at actually the first thing that I'm going to do, stand by, is I want to share a link with you because, hold on, I can't talk and click at the same time apparently. We are all going to start off by going to this Google Doc that I just put in the chat. And I'm just going to give you a couple minutes to define a word. All right, so I think there's 23 words. So I'm just going to call out your name and tell you which number you have so that we're not all like trying to fight over different words. So Tammy, I'm going to have you do number 1. Rainey will be number 2. Adriana 3. Remember your number because I won't. Jackie 4. Tallman 5. Robbie 6. Sarah 7. Tori 8. Sean 9. Alexis 10. Ian 11. Alyssa 12. Jacob 13 comes after 12. Ariana 14. Rulon 15. Ivana 16. Jonathan 17. Hannah 18. Andrea 19. Let me switch my page. Gabe 19. Lixie 20. Wendy 21. There's 2 of you, Wendy. Okay, Wendy, you're going to get 21. I think there's 23, but we'll just go with that. Okay, so everybody knows their numbers. Is the link working? Can anybody verify that? Yes, awesome. Okay, so here's the thing. You're going to look at the definition or look at the word, look at the definition, and then you are going to write it so a 5-year-old can understand it. That is your goal. All right, like you were explaining it to a little one. Unknown etiology is not what a little one would understand. Okay, like a 5-year-old. Okay. I love this. This is so awesome.
Miss Windsor, can you hear me?
Yeah.
Can you hear me?
Yeah. Can you hear me?
Can you send the link again? Because I'm having technical difficulties here. That's why I'm jumping off from my phone and my laptop.
Through the chat?
Yeah, can you send the link through the chat?
There you go. You see it now?
Yes, thank you.
Awesome. You're welcome. Okay, number 4, course. That's like a course of antibiotics, not like a class that we're taking. A course, like a treatment of medication, a round of medication. Does that make sense? Anonymous duck, anonymous platypus, anonymous hamster.
Hey, Miss Windsor, what was my number again?
I have no idea, Sean. Remember, I told you to remember it because I wouldn't remember.
I think you were 9, Sean. I think so.
Thanks.
Look for one that's not being done and jump on that one. I'm sorry. I'm not helpful. You have a good memory, Alexis. So invasive, whoever had number 17, is that not cutting you open or cutting you open?
Yeah, I don't know why I read non-invasive when I did that, so let me just.
No worries. They're right there together. That's why. It makes perfect sense to me. All right, so we're getting close. I see a couple more working. Nice job. Number 12 is very scary. That would scare me. Nice work, guys. So for palpation, that's really what's written in the book. But what about if you were describing it to a 5-year-old? Would you use different words than density? Or, I don't know, do you think a 5-year-old would understand that definition? Nice. Is there anybody that's still working, fine tuning? All right, so now I'm going to have you read your definition. So whoever is first can go first, and then we'll just go right down the line. Ready when you are.
Okay, etiology. Sometimes people get sick and it might be a bacteria or a virus. And then there are times we don't know what the heck caused us to feel icky or get sick.
I like it. You can really tell like Tammy has a little one. Like you would really be explaining it this way. That's awesome. Great job.
He's
Thank you.
5 and he watches Magic School Bus and they fly up someone's nose and talk about bacteria and viruses. So he gets it.
Absolutely. Absolutely. That is awesome. Thank you.
So idiopathic, and that is that sometimes something just happens suddenly, but we don't know why.
It's scary when we don't know why. We want to know why. Yes, absolutely. Thank you.
Morbidity and mortality. When people get sick, morbidity is the amount of people who get sick. Mortality is the amount of people who die.
That's scary. Thanks, Mom.
Course medicine that someone takes for a couple of days or weeks when they are sick so they can feel and get better.
Absolutely. Good job.
Describes how the cause of a disease leads to body changes or pathogenesis.
Good.
Okay, so I put for a sign, does your tummy feel like a hot potato or anywhere hotter like a potato? And I put symptoms. Have you seen Superman and Batman fall down? It looks like they have some red marks on them or funny looking colors. Can you show me any of that or hiding or feel?
Very good. So signs are something that we can see, remember that, and symptoms are something that we can't see or measure. All right, complication.
I put something bad and now it's really bad.
True story. Good, thank you.
Okay, exacerbation. When you don't feel good, sometimes things happen that make them feel worse. And sometimes they are your fault, and sometimes they aren't. The end.
True story. Very good. Who's up with syndrome?
Let's see. When you're not feeling good, what are all the ickies you are feeling? These groups of bad feelings are called a syndrome.
Nice. Very good.
Intermission, when your sickness is all better.
When it gets better. Yep, absolutely.
Relapse. Hey, little dude, remember that time I had a cold? I was all stuffy and sneezy and gross. I got better for a few days, and then out of nowhere I was sick again? That's called a relapse.
Indeed it is. Very good. Thanks, Ian.
Terminal, a sickness that can't get better, aka death.
Ugh. That's a bad word, death. Very good. Thank you.
Curative, people who are sick can get all better.
They could get cured. Yep. Thanks, Jacob. Who had palliative?
Oops, so palliative. To make feel better without fixing the problem, to make feel calm and soothe.
Good job.
Endoscopic, a tool used to look inside your organs, like your stomach. It's like a tiny tube with a camera and a light on it.
I love it. I love it. Good job. Thank you.
Neoplasm. It is a growth that is not normal, and it is what causes cancer, which is a sickness.
Scary. I don't want one of those.
Invasive. We are going to fix you by cutting you open.
Ouch. Good job.
Non-invasive, not cutting into the body or breaking the skin. For example, when the doctor takes a picture of your bone after falling down, or an x-ray.
Very good.
Transcutaneous, going through your skin.
Mm-hmm. Yep. And then our last one, palpation.
Feeling the body for the outline, thickness, and movement using my hands.
Yes, ma'am. Very good. Awesome. Oh, somebody did Doppler studies. Who did that one?
I did that one.
Thanks. You want to read it?
Yeah, it's taking a picture of your veins to measure the flow.
Thank you. Good job. Excellent. Did you guys like this little activity? Something different, collaborative, got you all involved. My diabolical plan worked. You guys did fantastic. Okay, now that we know what we're talking about, we're going to, let's see, what are we gonna do? I don't wanna share yet, hold on. I gotta pull up my PowerPoint. Ta-da, 1 second. Oh boy, now I'm completely lost. Where'd you guys go? Okay, here you are, I found you. Okay, here is our PowerPoint. Let me put it in some other kind of mode. Oh man. Okay, more than one way to skin a cat. Okay. All right, let me get the chat up here. So if you guys have questions, I can see what you're asking. Okay. All right, so as promised, diagnostic and assessment procedures, that's what we're talking about. here's all those words that we just defined, except for radioactive seeds. And we'll look at that a little bit later. So first, to start off, I thought some fun pictures would be good. So these are some different scopes. There are a plethora of scopes that we use for endoscopic procedures, depending on what we're looking at and how far into the structure we want to go. So if we're looking into a flexible tube like the colon, or down the esophagus into the stomach, or up into the ureter, maybe into the common bile duct, something like that, we're going to use something that's more like this little flexible guy. And they come in different lengths, right? And there's a viewing piece on this end, and there's a little doodad that sticks out. You can't really see here that this is the camera, would attach to that end there. And this is a light cord, which would attach to the, you can't see it on this one. Actually, with this one, I think it just plugs into a light source right there. Either way, we're going to be able to hook that to a video system so that we can look up on the screen and see what we're looking at, what the surgeon's looking at. And so sometimes we need flexible ones like that, and sometimes we use rigid ones like this. So bigger, longer ones are going to be for the abdomen, and they come in different sizes, and some of them are angled differently on the tips. And as we get more into specialty procedures, we'll revisit that. And then there's smaller ones that we would put inside of a joint, like a knee or a shoulder. There's even smaller ones that we could use in an ankle or a wrist. And this black eyepiece on the back is where the camera would attach. And the light cord is going to attach here on these little posts, and that's going to give us our visualization. So as the surge tech, one thing that we're doing is putting this equipment together. An important thing is to make sure that it all fits together before we get to the field. We want to make sure that this light cord, whatever end that it has, is going to attach to whatever we have for it to attach to. Sometimes there's different little pieces that we either need to put on or take off. Different systems aren't compatible with other systems, so it's really important to check that first. If that does not happen, that's an epic fail on the surge tech's part. And this is an example of what an imaging system would look like. We have 2 in our OR lab, and we'll definitely be doing at least laparoscopic cholecystectomies and knee arthroscopies. The circulator is typically the one that plugs in the opposite end to this equipment, the light, the camera, whatever the case may be. A lot of them also have the cameras have the ability to capture a picture or take a picture, and then there's a printer that is attached to the video system as well. So a variety of Tinker toys or Legos, if you will, and it's our responsibility to make sure those are all put together correctly and they all speak to one another. So vital signs, this is what we're going to be working on in lab next week. And on Monday, we're going to take a closer look at those vital signs as far as temperature, pulse, respiration, blood pressure. And we're going to be practicing that on each other. For an average temperature, we're looking at 98.6. I heard they did change it to like 98.7 or something, but in this textbook, it still goes with the old 98.6. But depending on where we take the temperature, we could get a little shift in the temperature. And the book goes over those. Like if you're taking it orally, then you may get a slightly different temperature than if you're taking a tympanic temperature, which is inside the ear, or an axillary temperature, which is in the armpit. Typically for little ones, that's where we take the temperatures in the axilla, And so you will just put the little temperature thing underneath their arm and usually just kind of help them to keep their arm down until the little machine beeps or whatever. You can get a temperature that way. Rectal temperature, we really don't do that anymore. Rumor is that you need a doctor's order to do a rectal temperature. That is not a standard of care. Pulse. Typically for pulses, and if you look on page 85 in your textbook, you'll see a chart at the top, a table 6.1, and it's going to show all the normal pulse rates and respiration rates for ages 0 through 18 and then adult. So you can see those averages there. For an adult, the average pulse is 60 to 100 beats per minute, but it's going to be higher in little ones, up to approximately 120 beats. So where do we commonly palpate the pulse? Which artery for adults? Who knows?
Radial?
Yeah, radial. Thanks, Sean. What about for babies? Any idea for babies?
Isn't it the axillary?
Yeah, so brachial. Yeah, but it's right up near the axilla in that little groove right by like their biceps muscle. And you'll be able to palpate it there. So that's typically where we do for infants. What was I going to say? Oh, when you're taking the pulse, you want to make sure you don't use your thumb. Just use your first 2 or 3 fingers because your thumb has a pulse of its own. So you might be feeling your own pulse instead of the patient's pulse. The radial artery is located on the thumb side of the wrist. So can you guys find yours? Can you find your radial pulse? Let me give you a couple seconds. See if we're alive. Are you guys alive? Oh, I found mine. I can feel it. I'm alive. Everybody else find theirs? Okay. Practice up on your friends and family for next week, okay? Questions about temperature or pulse at this point? Okay, let's talk about respirations. So respirations, when is the best time to assess respirations?
When the patient doesn't know that you're doing it.
Yes, when the patient doesn't know that we're doing it. So typically, if we don't have baseline vitals, when we do pulse and when we do respirations, we want to do it for a full minute. If we do have a baseline, then 30 seconds times 2 is acceptable. But typically we'll do pulse and then we'll fake the patient out by thinking we're still doing their pulse, but instead we're looking at chest rise and fall or abdominal rise and fall. So for respirations, an average adult, again, we can go back to that table and look for 0 years of age is about 30 to 40. So their pulse and respirations are going to be quite a bit higher than the adult, which is average 10 to 20. Now for the blood pressure, the top number or the big number is our systolic number, right? And that is the contraction or the stroke volume of the heart, right? 1 full beat of the heart, or squeeze, if you will. And then the relaxation is diastolic, and that is the bottom number. That's why it's usually smaller. If we were to take the top number and subtract the bottom number from it, we would get something called the pulse pressure. Now, orthostatic pressure is when we look at what's the pressure sitting up and then what's the pressure laying down to get an idea of that. And if you ever are doing vitals and you need to document, you're documenting, then you would need to document, was it sitting up, was it laying down, whatever the case may be, okay? Some physiological factors that can affect blood pressure. The book lists quite a few. Can you guys tell me what some of them are? Factors that affect blood pressure.
One is weight.
One is weight. Yes. Absolutely. Stress. That definitely affects my blood pressure. I can remember waiting to give a talk for Peoria High School, and my watch told me that it was worried about me because my pulse rate was 120. I thought, man, I need to calm myself down. My watch thinks I'm having a heart attack. So stress can definitely do that. Yes, strong emotion. It's that fight or flight thing, right? Yep, exertion can definitely do it too, right? When we're exercising or, you know, arranging furniture in the lab. And weight can definitely be one too. Yep, you guys got it. Other things that can affect it is the cardiac output or the stroke volume. So here we're talking about different diseases or conditions that can affect it, physiological factors. If there's heart disease or peripheral vascular disease or vascular compromise in some way, that's definitely going to affect blood pressure too, right? And then we talked about, you know, stroke volume. If there's lower blood volume, that's going to make heart rate go up. It's going to make blood pressure go down, but heart rate's going to go up, right? Because the body still needs the same amount of blood to be pumped around to get the oxygen to the tissues so that they can do what they need to do. So the heart's going to pump faster so that it can keep up with the need of the cells. And then lastly, that electrocardiography is going to be for evaluation of the heart, right? Going to allow us to see the electrical activity of the heart. As surge checks, we don't read EKGs or ECGs. We don't have to worry about that too much. Just an awareness of what it is good for us. So I'm going to skip this because we're going to talk, I have a video attached to this, but we're going to talk more about vitals on Monday. So I'm going to save this for then. And we're going to move into talking about some diagnostic imaging. And there's a lot of different types of diagnostic imaging. There's different radiographic imaging techniques. It is called Roentgenography, and that, if you remember, I think somebody did a presentation on that about Roentgen and how he was the one that first discovered this this type of technique and how gamma radiation can be used. And remember, he x-rayed his wife's hand, was like the first one. And so different types could include mammography, myelography, fluoroscopy, angiography, cholangiography, pylography, and GI studies. And I think we're going to look at some of the different ones, but I think one of the takeaways for us is that if there is some sort of diagnostic imaging that has been performed on the patient before they came to the OR, it may be pertinent that we have those studies in the operating room for the surgeon. Sometimes they're going to be old school, like hard copy ones that you put up on that light box. But more often than not now, they're electronic. And so there may be a computer screen that they will pull those up on. But sometimes they're going to want to see those, especially if it's like a breast biopsy. They're going to want to pull up the mammogram so that they can see that. So that's one thing for us to take into consideration, I suppose. Contrast studies. So when we do contrast studies, which we've kind of talked about in the past, some of the structures of our body, like you guys already talked about, we can't see on X-ray. So to get them to show up, whether we're looking at the GI tract or the biliary tree, vessels, those kinds of things, contrast may be ordered so that we can view those things. And cholangiography and angiography and retrograde pyelography are all procedures that we will come into contact with in the operating room. And so on your field, you're going to have some sort of dye. And an example down, I put down here, this is rhinographin. There are other flavors of dye as well. And there is a rumor that is not true about individuals that are allergic to shellfish or iodine having an allergy to the contrast. And even though it is a lie, we still go by that lie in the operating room. And if somebody is allergic to shellfish, we will use a different kind of dye. There's 3% of people that actually do have an allergy to it, but they say it is not associated with the iodine. However, we still treat it like it is in the operating room for some reason. So I did put those images up there just to kind of trigger your brain. And then this here is a cholangiogram catheter. This is the catheter right here. And there's another type that's like going inside this little introducer. But intraoperatively, we'll do cholangiograms. We'll be responsible for putting together this cholangiogram that comes in a kit with all of these fun little parts. Yes, we do have these in the lab. Yes, we will practice and demonstrate how to get all of this together, because you're going to have to draw up syringes full of saline and syringes full of contrast, and they get hooked up in a certain way, and things need to be flushed and tested and all of those things. So we'll be working with the cholangiogram catheter. And then when we talk about general surgery, we'll kind of dig into more of the technique of that. Suffice it to say that the dye that we use, we can work with intraoperatively, and we have to keep track of how much is used. All right, so cholangiography is looking at the biliary tree to see if there's any stones. Angiography, what are we looking at there?
Arteries, veins.
Yeah, you got it. We're looking at the vasculature. And then what about a retrograde pyelography? Anybody know about that? That's a big word.
Is that the nervous system?
It's not the nervous system. The myelography is like the spine, you know, the spinal cord. Let me see what it says. Yeah, Ian knows all about kidneys. So yes, absolutely. It's that it's the kidneys. It's looking up into the kidneys. So we can inject some dye into there and light up the ureter and the poles of the kidneys and check those out. Questions or comments about this?
I drank a contrast dye when I was getting a CT scan, and that's the iodine they gave me. It was flavored, and it had the consistency of Pepto-Bismol, like it was milky and thick and chalky, and it was really sweet. And before they gave it to me, they asked me if I'm a diabetic, but I wasn't. And you have to take the iodine like I think 4 hours before you get your CT scan, so it can go through your system. Yeah, I thought that was interesting to know.
Was that for your like digestive system that you were getting a CT on?
Yeah, digestive. I
Yeah.
had to drink 2 of those iodines. It was kind of pretty. It was pretty big, and I didn't really like it. It made me want to throw up.
Yeah,
It was too sweet.
That's not tasty at all. No. Yeah, so that's a great example of like a GI study, what they would do for a GI study. If they're going to look at like vessels, then they're going to get entrance into the vessel and just inject it straight into there. So there's different ways they can deliver the contrast. So that's a really good point. Thank you for sharing that. Awesome. Any other questions or comments about contrast studies? Contrast dye is super sticky. It's weird stuff. Okay, so these 2 pictures are really old. I don't know why I use these. I just thought they were like retro and cool, but so Rainey's asking about sentinel nodes. So for sentinel node, they're going to use a radioactive isotope. So a little bit different than contrast. Does that make sense? Remember when we talked about radioactive isotopes? That's like nuclear med. So they use that for like tissue marking. So we'll talk a little bit more about that. Yeah, of course. So 2 different types of X-ray or imaging that we would see in the OR are these portable radiography machines. A lot of them are a lot more sophisticated than this picture that you see on the left, but it's a mobile machine. They're going to roll it in, and the point is still the same, that this little part that takes the X-ray has got to go over our sterile field, and there isn't a drape for that. So for us, we're going to have to assist the surgeon with covering whatever area we're working on, because it's going to come over our field and it's not sterile. So that's one thing we have to think about. The other thing that we have to think about is sometimes the X-ray cartridge that they use is going to have to come into our sterile field. And so we have like these plastic clear pillowcases, for lack of a better word. They're called slip covers, and we can open those up on our field, and there's a cuff so that we can protect our hands, and the X-ray person's going to put that cartridge in there, and we're going to cover it, and then we can place that in our sterile field, or sometimes they prop it up or whatever, and then we'll go hide, and they'll take the X-ray, and then after the X-ray, it's our responsibility to get that cartridge back to the X-ray person so that they can take it downstairs, get it developed. If it's digital, it's a little bit different, but if it's like a hard copy, that's something that we might have to deal with. And then fluoroscopy. So the difference between this method and this method, what do you guys know? What's the difference between radiography and fluoroscopy?
Wear like a lead apron for radiography, or do you have to wear it for both?
Definitely for both. Fluoroscopy probably more, because it's like can be throughout the surgical procedure, where the radiograph is just going to be one image. So a lot of times the team will just go hide in the substerile room while they take the image of that. But yeah, so Ian mentioned that fluoroscopy is in real time, and that really is the difference, because a radiography is like you taking a picture of something. Fluoroscopy is like you're taking a video. Those are really the two differences, right? With one, you just get this one snapshot in time. With fluoroscopy, you can use it continuously. You can, manipulate the joint or whatever. You can inject dye and you can see the dye moving just like a video in real time. So speaking of video, I have a video about fluoroscopy. And I thought this was interesting because this is the C-arm is something that we have to put a drape on. And so as the surge tech, when the C-arm is being used, it's your responsibility to get this portion and sometimes this portion draped before it comes into our field. And so that is a fun thing. And I found this product that they were advertising that I thought is really interesting because when we do orthopedic procedures, they want two views typically. One is A and P, which is anterior posterior, where the C-arm is in this orientation and whatever structure is laying this way, it's going to take an anterior posterior front back image of whatever we're looking at. But a lot of times they also want a lateral view. And a lateral view means that this is going to lay down so it looks like a U instead of a C. It becomes a U arm. And when it becomes a U arm, you have this bottom part coming up into your sterile field. And we do a lot of weird things to try to kind of drape it off or put extra drapes or whatever the case may be. So without further ado, let's watch this and then we'll take a break. I'm gonna have to stop sharing and switch. Hold on one second. I have to switch to my video. Okay.
Introducing C-Armor, the surgical
C-Armor. Okay, let's see what C-Armor is all about.
drape designed to maintain sterility of the surgical field during lateral or horizontal fluoroscopic imaging. The C-arm X-ray tube breaches the sterile field boundary during a surgical case, rising from beneath the surgical table to a lateral position adjacent to the patient's surgical site. The Association of Perioperative Registered Nurses defines the sterile field boundary as the horizontal plane at the level of the waist or the surgical tabletop. The current unstandardized, inefficient, and wasteful draping techniques fail to achieve the guidelines of five-sided protection. Current methods include covering the C-arm with half sheets, U-drapes, Mayo stand covers, and other drapes that were not designed for this purpose. These methods breach the sterile field in several ways. Drapes fall below the sterile field line and are reused. Gaps occur in the sterile barrier. Surgeon and scrub technician contamination occur frequently. Focus is diverted away from the patient. Time is wasted during surgery at an average cost of $40 to $60 per minute, and materials are wasted from repeated draping. These problems create excessive red bag waste, increased room activity, and an increased risk for surgical site infection. There are approximately 500,000 surgical site infections per year, and 20% can be traced to contamination during surgery. A single surgical site infection can cost an institution up to $33,000, and Medicare, CMS, will not reimburse hospitals for certain hospital-acquired infections. The C-arm is utilized for both lateral and vertical plane fluoroscopic imaging in many surgical disciplines, including orthopedic and spine surgery, interventional radiology, and vascular procedures. C-Armor is a patented expandable and collapsible sterile pouch which adheres to the existing drapes at or above the level of the sterile field line using familiar adhesive tape. It lies flat to the surgical field, providing unencumbered access to the surgical site. When lateral plane imaging is desired, fasteners supporting the sterile pouch are detached, and the pouch is expanded to accept the X-ray tube. This process requires approximately 3 seconds. Once deployed, the drape provides five-sided protection and maintains its position at or above the sterile field line. When the C-arm is rotated back to the vertical orientation, the drape is returned to its original collapsed position. This technique can be repeated as needed throughout a procedure. C-armor can also act as a sterile pouch for the suction tubing and is clear, which allows visualization of the beam emitter for more accurate fluoroscopy and reduced radiation exposure. C-armor is simplistic in design, essential in purpose, and cost-effective. The benefits of using C-armor include reducing waste, eliminating costly time delays, and decreasing the risk of surgical site infection by reducing operative time, reducing room activity, preventing sterile field breach and OR team contamination, and reducing unnecessary institutional liability created by deviating from the standard of care. Now that there's a solution available, make the decision to treat your patients with the same standard of care that you'd expect for yourself or a loved one. Defend the sterile field with C-armor. For more information or to order C-armor, please visit c-armor.com.
Something strange was going on with my mouse. It was being crazy mouse. All right, what do you think? You guys want to buy it? C-armor? Yeah, are you for it? What are your thoughts?
Well,
Did that help?
he brought up a lot of really good points, you know, like just the cost and the movement and the OR and kind of everything that we've talked about we don't want to do.
Yes, and I cannot tell you how many times, like all of those bad things that you have seen, I have been a part of and privy to. For sure. Yeah, I like it. I've never used a C-armor. And I think it's been out for a couple of years. There are some different other products as well. I just thought that really showcased like how the C-arm works, how it moves in the sterile field, like those kinds of things, just to kind of give you a sense of what we're doing at that point as we're trying to like drape the C-arm, keep it sterile. It's going to move in, it's going to move out, it's going to move up, it's going to move down, all of those things, you know, and our job is to protect the sterile field. And so as such, that becomes a thing. Any other comments, thoughts, questions?
It's crazy. I always see that machine in the hallway when I go to work and stuff. It's cool to actually see what it does and how it's covered up and stuff.
Yes, thanks, Rulan. Yeah, there's also a little one called a mini C-arm that we can keep in the department that the drape kind of goes over the entire thing. It's like for hands and feet, works pretty well. But if we're going to be using the regular C-arm in the OR, then somebody needs to let radiology know because they're going to have to bring the machine up and they operate the machine. So at smaller facilities that I don't know, at huge facilities, what they do if one lives in the department and they just have an x-ray tech come to operate it or whatever. But at smaller facilities, it's like you have to schedule radiology to come, and you know, sometimes it can't be done on a moment's notice. So looking at the schedule, understanding those times when you might need fluoroscopy and knowing to ask those questions before the case, like, hey, are you going to need fluoro for this? And what that process is so that you make sure that it's there. It's just another part of anticipating the needs of the surgical team, even though isn't necessarily our responsibility. It's a shared responsibility probably between us and the nurse and the surgeon, but that, you know, knowing to ask those questions can save you a lot of grief interoperatively. I'm going to tell you. And for cholangiogram, the bed, the entire OR table has to be turned in a different orientation. And if you're doing a gallbladder, you better turn that bed before you start the case and get the patient on there. And even if it's not scheduled with grams, you probably need to turn it just in case, because I've been in quite a few cases where the doctor said we're not going to do grams, we didn't turn the bed, and then inevitably Murphy strikes and they decide they want to do a cholangiogram, and now the bed isn't in the right orientation, and that post and that base are in the way of where the C-arm would be able to come in and actually get the view of the patient that we need. So that is a real pain. So having that, knowing that, we're going to practice that in the lab. When we do lap choles, we will turn the bed so that you have that practice, and you know that's a trigger for you when you're out there. Any other thoughts before we take a break? Okay, I have 9:03, so how about 9:15? We will pick it back up, okay? All right, I'll see you then. Okay, but there's not, so this is how it is, so I'll just get over it, okay?
A CT scan is an X-ray procedure that creates cross-sectional images with the help of computer processing. CT images are more detailed than conventional X-ray images and can reveal bones as well as soft tissue and organs. A conventional X-ray uses a fixed tube that sends X-rays in only one direction, while a CT scanner uses a motorized X-ray source that shoots narrow beams of X-rays as it rotates around the patient. There are special digital X-ray detectors located directly opposite the X-ray source. As the X-ray passes through the patient, they are picked up by the detectors and transmitted to a computer. Image slices can either be displayed individually in two-dimensional form or stacked together to generate a three-dimensional image that can reveal abnormal structures or help the physician plan and monitor treatments.
See, I told you it was just a little snippet. A little 60-second science. Yeah, I thought it was informative, but kind of just short and sweet, right? So, getting back to my thing, and then I'll have to switch again. But in regards to CT, not a lot of that happening in the operating room per se, unless you have some seriously fancy OR suite where they do have some seriously fancy OR suites for like neuro, and predominantly they have some fancy neuro suites. So this is something that we don't really deal with intraoperatively, but preoperatively for diagnostic purposes. It's pretty awesome. So the next one we're going to look at is MRI. And again, more switching. I apologize. I'm getting in my clicking experience. It's going to go on the resume.
Arizona homeowners, if you have a power meter like this on the side of your house, you can
This is not
qualify
the video.
to erase your energy.
Okay.
Magnetic resonance imaging, commonly known as MRI, helps doctors find, watch, and treat medical problems. MRI uses very strong magnets, radio waves, and a computer to make pictures of the inside of the body. MRI pictures are more detailed than those made with other methods. There are many reasons to have MRI. MRI may find bleeding, such as bleeding in the brain. Brain changes, as in stroke. Problems with your back, such as a herniated disc. And an injury inside the body, such as a torn anterior cruciate ligament. Before MRI, you will remove all metal objects. And it's not safe to have MRI with some medical implants. You should tell the MRI technologist about any metal, device, or implant you may have in your body, such as a pacemaker. To prepare for MRI, You will lie on a table just outside the scanner. MRI scanners are very noisy, so you will probably wear earplugs or headphones. Different equipment, such as pillows and straps, will help you stay in the correct position. Once you are ready, the table will slide into the scanner. Most often, closed scanners, such as this one, are used. The area inside is very narrow. In some areas, open scanners are available. This scanner is open on the sides, so you won't be completely surrounded by the machine. However, the pictures may not be as good as with closed scanners. For either type of scanner, a technologist will operate it from the next room. You will be able to talk to each other through a two-way speaker. During the scan, magnets in the machine will create a strong magnetic field. This will not harm you. Then, the scanner will send radio waves through your body. This will not harm you. When the radio waves are turned off, the scanner will pick up energy signals from your body. These signals are used to make the pictures. During the scan, you will have to stay very still so the images will be clear. You may be asked to hold your breath for a short time. MRIs may take 30 to 45 minutes or longer to complete. In some cases, you may get contrast dye with your MRI. The dye helps make clearer pictures. After the MRI, you can resume your normal activities. If you received contrast dye, the technologist may ask you to drink plenty of water or other healthy drinks to help your kidneys remove the dye from your body.
Anybody have any personal experience with MRI? No, Tammy, you have? Gabe, I see your hand. What was that like? Jonathan, too, was that for your ACL? Yeah.
Mine was before I got hearing aids, and due to the hearing loss, they wanted to make sure there wasn't anything behind my head or in, behind that area and everything, like a tumor or anything like that. So it's loud and it's cold.
Mhm. It's super loud. That's one of the things I remember the most is how loud it is. And then you can't move. Like you're supposed to stay completely still, which is a little bit unnerving, especially when it's hard and uncomfortable and cold and weird in there.
Yeah, the amount of times we've had to, because I've worked down in MRI before as like the tech, well, not the tech, as the aide.
Mhm.
And the amount of times we've had to just send people back upstairs because they can't like sit still through it. And a lot of people have to come out because they're claustrophobic or just anxiety.
For sure, for sure. I had a thought about that. One of the reasons that they have to keep it so cool in there is because to keep the machine cool. And so it's hard not to shiver even though they give you a blanket. Oh, so was that the contrast, Ian, that made you feel that way? Or did they inject something or was it? Because I know, yeah, when they inject the contrast dye, that feels really weird. Like you like get a warm feeling, and there's like, it can cause like an increase in heart rate and blood pressure and those kinds of things. And then if you have a history of kidney disease, Not good to have contrast studies. That's usually contraindicated for that. Yeah, fun stuff. Fun stuff, MRIs. All right. A really important thing is not having any metal on or in when you are having the MRI. There's a crazy YouTube video where they have like one of those gas, like metal gas cylinders in the room at adjacent to, I think, the MRI. And when they activated the MRI, it literally like shot it through the wall. So no metal. Although my mom tells the story of being super embarrassed because she asked if she could wear her underwire bra. Like, yes, that's fine. And she's like, I gave away that I wear an underwire bra. I better be quiet. She could hear me telling her stories. Okay, so PET scan. PET scan, PET, stands for positron emission tomography. And a lot of times, like, they will use these types of studies for like looking at brain activity and stuff like that. So I have another little quick video for this one as well. Again, I apologize for the switching. I know it's weird. I guess next time I'll just have these lined up and not attached to the PowerPoint. Be easier.
A PET scan creates 3D images of the body. It does this by using radioactive tracers, which are usually administered to a patient through intravenous injection. The tracers are made up of carrier molecules that are tightly bonded to a radioactive atom called an isotope. The carrier molecule can interact with or bind to specific proteins or sugars in the body. The carrier molecule that will be used depends on what the doctor is looking for. If she suspects cancer or is monitoring a known cancer's growth, she may use FDG, a modified form of glucose, which gets absorbed by tissues. When tissues absorb a lot of glucose, it may indicate a cancerous tumor. The radiation from the tracers poses little danger to the patient since they quickly pass out of the body. The isotope produces small particles called positrons, which interact with surrounding electrons. This interaction results in the complete annihilation of both particles, releasing two photons that speed off in opposite directions. The detectors in the PET scanner measure these photons and use this information to create an image of the distribution of FDG in the body.
Isn't that awesome? I'm going to be a physicist in one of my lives. All right, that there is the PET scan. PET scan. So like I said, a lot of times they will, this is kind of gives us a visual of chemically what's going on in the body as well. And then there was ultrasound. So let's take a look at ultrasound.
The heart of most ultrasound systems is a device called a transducer, which uses an array of piezoelectric crystals. A piezoelectric crystal vibrates when an electric signal is applied, producing high-frequency sound pressure waves, which we call ultrasound. More importantly, this type of crystal can also work in reverse. It can produce electrical signals when it detects high-frequency sound pressure waves. When a transducer directs ultrasound waves into the body, they pass right through the skin and into the internal anatomy. As the waves encounter tissues with different characteristics and densities, they produce echoes that reflect back to the piezoelectric crystal. This happens more than 1,000 times a second. Returning echoes are converted to electric signals, which a computer converts into points of brightness on the image, corresponding to the anatomic position and the strength of the reflecting echoes. A medical transducer contains a large array of crystals, which allow it to make a series of image lines that, together, form a complete image frame, called a sonogram. In addition, all the crystals are repeatedly activated many times in such a way that a complete image frame is formed around 20 times per second, so that real-time motion is displayed in the ultrasound image.
Awesome. So because that is not a type of diagnostic imaging procedure that uses gamma radiation, it is good for baby. So if you've ever had one, then chances are you've had ultrasound to see what that little baby looks like and what they're doing and how they're developing, that sort of thing. This is one of the diagnostic processes that we can use intraoperatively as well. So PET scans, MRIs, CTs, not typically used intraoperatively, but ultrasound definitely can be. And one way it's used is with the Doppler. And so I have this image up here. If you can see, it is an example of a type of Doppler. There is some sort of kind of pencil-like device with a cord that will be sterilized and would get opened onto the field along with some sterile like ultrasound gel. And then there's going to be some sort of receiver that's off the field, that's not sterile, that the nurse is going to plug the other end of that cord into. And then we can use this to listen to the flow of blood, the rush of blood through vessels. It sounds like a swish, swish, swish sound. You can see them doing that right here. And it can also help them to identify different vessels, nerves, those kinds of things. So something that we might use intraoperatively as well, but it is safe for also looking at delicate structures like the developing fetus because it does not use gamma radiation. Questions about any of those or comments? Okay, so the next thing that the book talks about is blood, different types of blood tests. And we've talked about these before in A&P, the complete blood count or the CBC, hemoglobin, hematocrit, which is the platelet count, and the leukocyte count. Metabolic panels that are looking at different chemicals in the body, coagulation tests, arterial blood gases, different blood types, and electrolytes. So I thought I had more information on those, but some things to point out regarding these, while they are diagnostic tests that typically happen before the patient comes to surgery, they are some tests that can happen intraoperatively too. A couple of those would be the arterial blood gases. They can actually have someone come into the operating room and take a arterial blood gas intraoperatively. We've also talked about giving the patient blood intraoperatively. Coagulation tests predominantly have to do with how fast it takes the patient's blood to coagulate. And this is important when we have a patient that has been anticoagulated. So if they've been given heparin, which is an anticoagulant, or if they're on some sort of anticoagulant medication on a regular basis, like warfarin or Coumadin, or there's some other ones as well. So not too many of these things are happening in the OR, but just a heads up on if somebody is coming in to do a blood draw or an arterial blood gas, then we just want to make sure that we watch our field, that they have on their right PPE, those kinds of things. And maybe give them a gentle reminder of, stay 12 inches away from anything that is blue. Additional studies like urinalyses can happen preoperatively, where they're looking at all different types of stuff in the urine, whether it's bilirubin, protein, albumin, sugar, pH, color, clarity, odor, taste. No? Okay. And then microbiological. So I put this little picture up here. This is a culture swab, something similar to what we might see in the OR if we encounter some kind of strange fluid or whatever, and the surgeon wants to culture it. And then that could be sent off for that culture and sensitivity like we talked about before in microbiology. Tissue biopsies. So we as surg techs, we handle specimens. That's one of the important things that we do. And when we get more into wound care and, specimen handling, we'll like revisit this stuff in quite a bit more detail. But here's a look at some of the specimen containers that you might see. There's also like big buckets. They come in every single size that you can think of. But we're gonna have two types of specimen containers. One that are empty and they're sterile and they have nothing in them, or ones that are not sterile on the outside, that are just housed in the substerile area, and they are pre-filled with formalin, which is that preservative. So it may come either way. As far as tissue biopsies, there's a lot of different choices that we have as far as excising some tissue to send for a specimen, doing a needle biopsy or a punch biopsy. I kind of put in bold the ones that we would see most frequently in the operating room, like aspiration if they want to take some fluid. That might be a type of specimen that we have, or a frozen section where they're doing some sort of biopsy, they think it's malignant, they send it off to see if we got all of the tumor out or skin cancer, whatever it is. Calculi, which are stones, right? With stones, we want to make sure that we don't put them in formalin. They need to go in alcohol because formalin will destroy them. Amputated limbs, bullets, that's always a fun one. And then if we brought them in to remove prostheses, the surgeon might want those sent as well. Here's some images for you. The first one, if they're doing some sort of fluid biopsy, they might use, this is called a specimen trap. And this can hook right to our suction is going to go here. Our suction tube that's on the field, the suction tip can go onto this end, and then it will suction fluid into this little container here and fill it up, and then we can pass it off to the nurse. This over here is for a bone marrow aspiration and biopsy. So this is called a trephine biopsy needle. And so they could essentially drill this, hook it up to a power tool, drill this into the bone marrow and get a core sample of the bone marrow. There's an amputated limb for you. Something that I thought about when I was reading this material is when we're taking out specimens that are cancerous, they're malignant, like this is skin, it looks like to me, they're going to want to mark the margins of the specimen. And so you can see these little strings that are coming off from the specimen. That is suture that the surgeon has put on there. And when they mark the margins, they're going to tell you what margin they marked, and if it's a long stitch or a short stitch or whatever the description of that is. And it is super important that we pay attention to that and we communicate that correctly to the nurse, because that is going to go on the pathology slip, is going to go to the pathologist, and that information is how the pathologist is going to be able to orient the specimen. So when he studies it or she studies it, and there are still cancer cells on one of those edges, they're going to need to tell the surgeon where he or she needs to take more tissue from. So it is imperative that we get that information right when we are communicating that to the circulating nurse. And then the last one is what we call a needle biopsy or punch biopsy. They're these special little disposable trocars that can take like a core sample of tissue, whether it's the liver, the spleen, the whatever. They can, for soft tissue, more for soft tissue than for stuff like bone. Questions, comments about that?
It's crazy how misplaced the arm looks when it's severed like that. It looks like it's fake, but you know.
It does look fake. I was gonna put some eyeballs in here, but because I know how Rainey likes eyeballs, but I didn't have enough space.
It makes you wonder why by looking at it. You know, you're like, why was it amputated? What was the cause? I mean, it looks.
I was just thinking that. I'm like, that looks like a perfectly good arm. Why is it there by itself?
I'm
What
like,
is the story behind that severed limb?
Mhm.
Let me see. Hold on. I gotta pull my little chat out so I can see. Lixie says she throws limbs into the fridge all the time. Oh, that's so funny. I just don't want it anymore. I'm tired of that arm. Let's get rid of it. Yeah, my dad actually works with a gentleman, and his wife was in a really bad car accident about 3 years ago. She was on a just a two-way road, and the gal that was driving towards her was texting on her phone and hit her head on, and she was completely crushed by her like lower body by the dashboard of the vehicle. And so she had a fractured pelvis, she had fractured leg bones, and it like pulverized her ankle. And so for 3 years, she's been fighting with this ankle. She's had infections in it. They tried to do an ORIF. She got reinfected. They took that out. They did a total ankle. She got infected again. They took that out. They did a revision of a total ankle. And now it's infected again. And so she's making the choice to have it amputated. Yeah, because it's just this chronic source of horrible pain. The next step is for them to completely fuse her ankle. And she's to the point where she's like, I don't want it anymore. In the words of Ian, I can't say it any better. So sometimes that is the situation. In regard to cancer, there's some terms that the book talks about. It talks about a neoplasm, which we defined as a cancer type growth. We are familiar with terms malignant versus benign, or cancerous versus non-cancerous. We are familiar with metastasis, which means some source of cancer traveled to another area and set up shop in the body. Nuclear medicine is where we're going to get those radioactive isotopes, or those chemotherapy seeds, radiation seeds, excuse me, that we might use in a situation like this one right here, which is representative of what's called brachytherapy. And brachytherapy is where they have identified prostate cancer. And so they'll bring the patient in, we'll put them in the lithotomy position, and they're going to insert this device into the rectum. And then this that you see right here, if we could look at the front of it, you would see that it looked like a grid, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, A, B, C, D, E, F, G. As the surge tech, when the seeds come from nuclear med, they're in like this solid lead doohickey that has to be put into the flash sterilizer. So once that is flash sterilized, then your job is to get it out. Once you're sterile, you need to count how many seeds are in there And before they're ever brought in, they're going to do a swipe with the Geiger counter. So this is a Geiger counter right here. It measures the level of radiation. Before and after, it should be nil, all right, or close to none. So they're going to sweep with the Geiger counter before, and then they're going to sweep with the Geiger counter after. As the surge tech, your responsibility, besides making sure that the oncologist doesn't just completely contaminate everything, is keeping track of how many seeds you start with, like knowing how many seeds you start with, 20, whatever, and then how many are used intraoperatively. And you are also going to draw this grid on your back table. So you'll have a marking pin, you will draw that exact grid, and they are going to tell you, like bingo, okay, we placed 1 seed in A7. Okay, you're going to put a mark there. Okay, we placed 1 seed in L2, whatever. And you're going to record that. That's going to be your responsibility. And then that is going to be documented in the patient's permanent record. Now you can see here the size of the seeds compared to a penny. I thought that was kind of interesting. But there's these long needles and they're disposable. These are called brachytherapy needles. And I do have some in the lab and we can take a peek at those when we get to that point. So this is just one example of how nuclear med is used. That other example is that Rainey had brought up the question about is for sentinel node biopsy. And we would get the syringes filled with the radioactive isotope from nuclear med as well. Those have to be counted. We don't do that, but the nurse will record how many are used. The surgeon will inject the radioactive isotope once the patient is in the room and asleep. So before the patient is prepped and draped, they're going to inject the radioactive isotope. It is going to collect in the axilla and concentrate itself in that sentinel node. They will probably also inject something like methylene blue or indigo carmine, gentian violet, whatever, some blue dye. They're going to also inject that near the areola as well. That is going to give them the visual cue of the sentinel node. And then they'll have a special device for detecting that radioactive isotope. It looks like a little wand. It's cordless, and you're going to have to drape that. And that put a little plastic cover over it, and that's going to come onto the field, and the surgeon is going to use that in the axilla like a metal detector, right? It's going to beep more frequently, and the machine is going to show like higher numbers of the isotope so that they can identify that sentinel node and remove it. Questions, comments? Cancer terms and concepts continued. So the book talks about tumor markers and tumor staging and different grades of tumors. And that's all kind of confusing. So I just kind of tried to cook it down here and give us some images that would kind of make sense. So tumor markers are chemicals that the cancer cells release, and some cancers have these very specific chemicals that they release, and you can see some in the image here. A common test for prostate cancer, or to diagnose or determine if prostate cancer is called the prostate specific antigen, or PSA. So if you've ever heard of that, that's for diagnosing or assisting in the diagnosis of prostate cancer, but you can see some other ones here as well. It's not a be-all, end-all, the tumor marker. It's just one part of identifying or diagnosing with cancer. And then there's the tumor staging. So tumor staging helps to classify the tumor. What kind is it? How serious is it? And then helps the healthcare providers select the best treatment for the patient. And it can also indicate progress of treatment. So, you know, is what we're doing actually helping the patient or not? And that is something called TNM, and T stands for tumor, and then N stands for lymph node involvement, is there, isn't there? And then the M stands for metastasis, or extent thereof. And then there are also grades of tumors. So if you ever heard they had stage 4 pancreatic cancer, well, that's where this comes from, or that would come from. So grades are the level of cellular differentiation. So the more differentiated cells are, the less chance they're cancerous. So the more similar they are, or the decrease in differentiation, the more serious the disease, the higher the grade. So grade 1 cancer, not nearly as serious as grade 4 cancer. And so I found this image, and I thought it's kind of complicated, but if we look at it, as far as you can see that this stage is stage 4 at the very top, 3, 2, 2, 2, 2, 2, 2, and then 1. So if we start here, is there distant metastasis? Yes. Okay, if there's distant metastasis from the tumor, then we have stage 4. That's how we classify it. And these are some things: inflammatory carcinoma, yeah, I don't know that. And then ulceration or extension to the chest wall. Let's say we have some sort of breast cancer. You can see here, it's going to cause skin disruption, those kinds of things. If no, then we look at the next, inflammatory carcinoma, chest wall invasion, or ulceration. Yes, then we have 3. If not, then these characteristics are of stage 2. And then if there's no lymph node involvement, we're looking at either stage 1 or beginnings of stage 2. So again, stage 1 being less severe than stage 2, being less severe than stage 3, and so on and so forth. That's the only takeaway we need here. Prevention and intervention. Early diagnosis is what's going to save someone with cancer in the most part. So some things that help with that can be medications, also lifestyle choices, the correct treatment, screening, which is really important, vaccines, and surgery. So those are ways that we can intervene as far as cancer is concerned. And I liked this little one that was like step 1, step 2, step 3. So step 1 is awareness and having access to care, right? That's a big one. So awareness of symptoms, seeking and assessing care. And one of these simple things that we can do, right, is a breast exam as women. When you're in the shower, you know, you gotta wash them anyways. Might as well just do a self-exam. And for males, for a testicular exam, again, both of those things are really important, just, you know, to assess if there's any sort of abnormality. So an awareness is the first thing. And then having access to care and actually getting care. And then access to treatment as well. So anyways, do your due diligence. And then I thought this was interesting. Know what cancer screenings are for you. So this is a little checklist for women and men. For women, it says ages 20 to 29, that they should have a clinical breast exam every 1 to 3 years to check for breast cancer, and a PAP every 3 years. Now, if there's been something abnormal with a PAP, then they suggest every year for 10 years. And then once you've had 10 years with no abnormal pap smears, then you can go back to that every 3 years. But that should be started at the age of 21. Ages 30 to 39, again, that clinical breast exam and the PAP, and the HPV test they suggest as well. And at age 40, ladies, we should start getting our mammograms, and those should be annual. And then 50 or older, continuing with all of the above and adding in the fun of a colonoscopy every 10 years. I love the virtual colonoscopy. I'm not sure what that means. But
Do you back your bum up to the camera? I mean, how do you do a virtual?
oh, but I think that's awesome. When I had a teledoc appointment, she's like, do you have a window that you can face and then open your mouth really wide so that I can look down your throat? I'm all, oh my gosh. Okay, so yeah, maybe, I could be that.
There's gotta be some limits. Come on, people.
I don't know. Maybe they send you an at-home kit of some kind. Oh, maybe it's where you swallow the camera. You swallow the little bitty camera and then you poop it out and it takes pictures while it's like swimming around in there. That's probably what it is.
Yeah, but don't you have to then fish that sucker out?
I don't know that you have to fish it out.
Oh, I hope not.
I don't really know that, but
there's some lines that just have to be drawn.
You know, right? I know my mom said her little brother swallowed a penny, and her mom made sure she fished it out, or she made sure that it came out. I was like, oh. And then last is, getting the lungs screened as well. And then for men, let's see what men have going on. Not nearly as much fun stuff as women, let me tell you. So men, listen up. 40 to 49, you need to talk about prostate screening. Very important. Get your prostate checked, get a PSA, whatever. Age 50 and older, still continuing with the prostate exam, and you get to add in the colonoscopy and the lung cancer screening. Okay, so those preventative, well, not preventative, but screening measures, right? Early detection is key and is what's going to save our lives. So self-care, people, self-care. What questions you got? Throw them at me. I'm going to stop sharing. Even though it is caring, sharing is.
Does prostate cancer always end in the removal of the prostate?
I don't think it always does, no. Sometimes the brachytherapy will work, so they can treat with that, and so it's a less invasive method. I think it just depends on the patient and the aggressiveness of the cancer, but no, not always. Good question. Other questions?
Is it pretty common to have a lot of these, or I don't know, even any particular type of diagnostic test done during surgery? I mean, something other than the C-arm or, fluoroscopy or whatever. I'm just wondering, how common is that, regardless of whether, is it more common, say, with neuro than it is with, say, ortho or, something like that? But is it pretty common during surgery to have these things done?
Good question. I think it kind of is specialty specific. One thing that jumps to mind is Angiograms. Like if we're doing something vascular, an angiogram is probably something we're going to do intraoperatively, regardless of if they have a clot or we've done some sort of bypass graft or something like that. So I would say angiography is pretty common with that. When we have urology, then they typically do some sort of retrograde pylogram. And, you know, so that's pretty standard. And then that also uses fluoroscopy. So, and with ortho, most of the times we're using fluoroscopy if it's a fracture. So that's kind of just a commonplace thing. Some surgeons, one surgeon I worked with, when he would do hip replacements, he liked a flat plate x-ray at the end, just as a confirmation that, you know, physically everything looked good. So those are the first things that jump to my mind. You know, cholangiograms are very common intraoperatively with lap choles. Let me think about the other things. When we're dealing with cancer, frozen sections are very common. Now that's just specimen handling and then some waiting on the other side of it as far as diagnostics, you know, or maybe we're not sure if it's cancer or not. So we take a bit out, we send it to pathology, and then we're kind of waiting to get that diagnosis to know if we need to remove whatever it is or resect something. So if there's a question of cancer or there is cancer, those things are going to be really common in those procedures. So I would say it's really specialty specific depending on what diagnostic tests we're going to be doing intraoperatively. Does that help?
Yeah, absolutely. I'm just finding it really interesting to recognize and realize just how technological this position really is. It's not just cutting up and, you know, scalpel suction. You know, there's a lot more to it. So I'm just finding that really interesting. Thank you.
Yeah, absolutely. There definitely is. I can remember there's a special type of device we use called, well, it uses radio frequency. And so there's these radio frequency devices that sometimes we use. There's radio frequency ablations. So now instead of doing a vein stripping and taking the entire saphenous out, they do something called an ablation where they put this special little wire catheter down the saphenous, and the radio frequency ablation actually seals the vessel, seals it up instead of having to like rip it out. And so all of that equipment that we're using on our end, we need to know how it goes together and how it comes apart. The cleaning of it, does it get disposed of? You know, does it have to be disassembled when we send it back to processing, or what parts get thrown away? Because sometimes there's a keeper part and there's a throwaway part. And then the machine that it connects to. It's our responsibility to know how that works as well and how to operate it. Typically the nurse is going to be operating it, but we're all in-serviced on it. So intraoperatively, if you're with a nurse that hasn't ever used it before, you're going to have to lead the nurse through how to hook it up, how to turn it on, how to use the adjustments, all of those things. So, and I think that's one reason why we used to be technicians, but we are no longer technicians. We are technologists. That means we are specialists in knowing not only what is used, but how it's used and when it's used and why it's used. That's my spiel. It's crazy. It's so multifaceted, which to me is one thing that makes it so awesome. Yeah, but it's a lot. Other questions, comments? Are you guys ready for a little break? I've had you for about an hour. Okay, so it is 10:05, so how about 10:15? Okay, I'll see ya.